For this I am going to start the procedure with a side viewing scope. In general, the side viewing scope differs from the standard gastroscope in that all the instruments are to the side. And to show you this, let me show you the tip of the scope. The camera, as it zooms in, you can see the tip of the scope here. There is a working channel, there is an elevator here, and there is the light source. The light comes from the side, so it's a side viewing scope. The difference between this scope and the standard gastroscope is that when you actually intubate with the scope into the esophagus, you do not see the esophageal lumen well because you are very close to the wall of the esophagus. You see only the distal part of the esophagus, so that's the difference. The initial intubation is different. Now we are going to intubate this patient now. The patient is in a semi-prone position. We start first with a blind intubation, and because the tip is rounded, it's fairly easy to put it into the esophagus. Once in the esophagus, you can see that the scope is extremely close to the mucosa, so you do not see the lumen actually. When I come to the distal part of the esophagus, what I do is to actually push the big knob down like this. When I push the big knob down, the scope turns, the knob turns towards the lumen, and you can see part of the lower end of the esophagus, and you can see this very nicely here. And as I enter into the stomach, I am now in the stomach, and the first thing I do when I enter into the stomach is to turn my scope to the left, extreme left, and suck out all the secretions here in the fundus. Because these patients are sedated, she is on propofol anesthesia, so I don't want to take any risks of aspiration, so we are sucking out all the secretions here. And once that is done, I straighten my scope and then I look for the lumen of the stomach. One of the things that you might have to do sometimes is to turn your knob a little right so that you can see the lumen better. And then the next step I would do is to turn the big knob down. When you turn the big knob down, the side viewing endoscope actually becomes a straight viewing endoscope because the scope now faces up like this. And with this big knob down, I try to go down into the stomach, looking at the pylorus constantly. And you can see that I am going into the stomach. I am not distending the stomach too much because we don't want too much air in the stomach. As I go down up to the pylorus, I will come to the area where I can see the pylorus well, and you can see that we are approaching this area now. At this point of time, I can actually look at the stomach, look at the incisura angularis, and look at the scope above. And as I go further down, I will come to the pylorus, and this is the area where the pylorus is. You can see it in the distance there. The technique of going through the pylorus is actually not to push your scope down like this, because then the scope will retrovert and go into the fundus, but to straighten the scope. And when you do this, what happens is the pylorus actually goes away from the side. So it's called the sun setting sign. So what I'm doing is, as I'm pushing, you can watch my thumb here, I'm going to straighten the scope and push the scope. The pylorus disappears in the site as you simultaneously see it on endoscopy, and then it goes out of the view. You can see this now. So I'm now in the duodenal cap. Once in the duodenal cap, very close to the cap, you will see that the villi very nicely because the scope is very close. And then what I do is turn the knob to the right, the small knob to the right, and fix it there. I then push the scope down a little so that I see into the second part of the duodenum. Once I do this, the most important steps come now, because if you actually look at the scope on fluoroscopy, you will see the scope is in long position. This long position is not ideal for cannulation. We have to straighten the scope. So what I would do is to turn my body to the right, to put the big knob up, and then pull the scope out. So these three movements are very important. Turn the body to the right, put the big knob up, and then actually to pull the scope out. And as I do this, you can see on the fluoroscopy simultaneously that actually I am now going down into the second part of the duodenum and seeing the papilla there. And when I finish this procedure, you can see the papilla nicely in position there with a straight scope. So this is how one should actually shorten the scope. So it's very important that the scope is in this straight position rather than long position for all your procedures. And you can see very nicely here, both on the fluoroscopy and on endoscopy, that the papilla is facing us. Now how do we identify the papilla? You will see that endoscopically there is a longitudinal fold which starts from the junction, the second and third part of the duodenum, and goes up to the papilla there. The papilla is a small mound, and on top of it you will see this very nice appearance of a villa type of appearance. This is typical of a frond-like appearance, which is very typical of a papillary opening which is there. You see also some bile coming out, which is a good sign for us. That means cannulation should be relatively easy in these cases. So this is how a papilla is identified.